Hello everyone, welcome to the second part of general examination in which we'll be going over the pickle findings होती है. So PICCLE, pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema. These are the various findings that you have to elicit in this one. Also we'll be talking about our favorite, our JVP, that is the jugular venous pressure. So in pickle, before I go into the exact details about how do you do it, let me give you a bit of the significance of it. Let's start with pallor. Pallor will basically see how pale the patient is. We'll see if the mucous membranes are flushed red or are they pale. That means they are appearing a little bit white. So that's what we call as pallor. And pallor may, the main significant finding that you need to remember is anemia. So anemia, if the patient has, the patient will definitely have pallor. What exactly is anemia? It is a decrease in RBC mass. So that is decrease in either HB of the patient or decrease in the RBC counts or both. That will give you anemia. Now there are various causes of anemia that you can definitely read in your theory books. That is the different types of anemia on the basis of the size of the morphology of the RBC. But I'm not here to discuss all of that theory. I'm here to tell you the practical stuff. The question that a lot of the examiners ask is, what if the patient has normal HB, normal blood count? Why the patient still has pallor? It might happen, right? That the patient is looking very pale, but the patient is absolutely fine. He has HB of 14 grams. So how is this happening? So this is the main question that you can address over here, is that what is the causes of pallor without anemia? And one of the most important causes that you have to remember is, first of all, hypothermia. Hypothermia means there is vasoconstriction. So we will have pallor basically. Secondly, there is what hypopituitarism. So in hypopituitarism, there is the same thing that's going to happen. Next, we've got hypotension. So in hypotension, the same thing. The blood will be there, but it will not be able to reach everything. Congestive heart failure. There also you will get a pallor, which is present in the patient. Otherwise, if you have taken some drugs which are blanching the vessels of the eyes, so those will also cause pallor. So these are a few causes of pallor without anemia. There is also scleroderma. So you might have heard about scleroderma. It's a rheumatological condition in which the patient will have pallor. Next, moving on to the icterus part. Icterus part is basically seeing if the eye has the yellowish tinge to it. So if the conjunctiva basically has got any yellowish discoloration present over it. So actually conjunctiva sclera, it's a controversy ki exactly which part of the eye gets stained. So for all practical purposes, let's just consider it to be conjunctiva, right? So in conjunctiva, we've got the bulbar conjunctiva as well as the forniceal conjunctiva as well as the main palpebral conjunctiva. So we'll be checking for yellowish discoloration on that part. What is the significance of it, my dear friends? Icterus happens when patient's bilirubin level is increased. A jaundice might be clinically evident after the bilirubin level has gone down above 2.5. So before 2.5 milligrams per deciliter, the jaundice will not be visible in the eyes. Normal bilirubin levels are less than 1.2. So when they go above 2.5, that's when you get the jaundice actually showing. So we check it on the various surfaces, but most importantly, we have to check in the conjunctiva. So that is how you actually see the bilirubin levels. Now there are various causes of high bilirubin, all of them pertaining to liver diseases, some of them being hemolytic. Just to summarize it a bit, the icterus or jaundice can be prehepatic, hepatic or post-hepatic. Prehepatic is when the blood is having some sort of issues. For example, you might have hemolytic anemias where RBC is being destroyed, hemoglobin generated. From hemoglobin you will get bilirubin. Next you will get the hepatic causes, for example viral hepatitis, non-alcoholic fatty liver disease, alcoholic fatty liver disease, Indian childhood cirrhosis. All of these are different causes of hepatic elevation of bilirubin. Next we got the post-hepatic causes. In post-hepatic causes, very important is obstructive jaundice. There can be various causes of obstructive jaundice, one of the common being gallstones. CA head pancreas can be there, periampullary carcinoma can be there, CA gallbladder can be there, cholangiocarcinoma can be there. It might be post-operative stricture might have been formed. So that will be all the causes of post-hepatic jaundice. So in short, whenever bilirubin more than 2.5, you will get icterus. Next, we will be moving on to cyanosis. There are two types of cyanosis. We've got the central cyanosis as well as the peripheral cyanosis. Central cyanosis will actually manifest in a few different conditions. Peripheral cyanosis is a reversible condition that happens transiently. It will go away. Peripheral cyanosis we see on the peripheries, of course. So we got the hands, the tip of the nose, the ear lobules, the lip. This is where you see the peripheral cyanosis. The central cyanosis we see on the tongue and the oral mucosa. That's where we see the central cyanosis. The causes for central cyanosis, my dear friends, can be related to the, first of all, heart, in which we have got the congenital cyanotic heart diseases. So we can remember them as T-Wally diseases, tetralogy of Fallot, transposition of great vessels, total anomalous pulmonary venous circulation, that is TAPVC, truncus arteriosus. Then we've got Epstein's anomaly and Eisen-Mengerization. So 4 T's and 2 E's is the cyanotic congenital heart diseases. Next, we have also got a few conditions in respiratory system which will lead to cyanosis. So type 1 respiratory failure, that is hypoxic patient patient will be there, and that will lead to cyanosis of the patient. And nextly, we've got mixed cyanosis. So in mixed cyanosis, both central and peripheral will be there, and this usually happens due to some sort of ASD or VSD which is present, which is causing mixing of the blood. So that is the few causes of cyanosis. Peripheral cyanosis due to heart failure can happen, due to shock it can happen, due to hypothermia it can happen. Peripherally cyanosis will happen. It also happens during Raynaud's phenomena. These are the various causes of cyanosis. Very essential to know is that if you see a cyanotic patient, you have to also examine him for clubbing. So that is the fourth point that we have to look for is clubbing. So clubbing is basically increase in the nail bed diameter. So it will only happen in a very specific set of conditions. Let's talk. With respect to the heart, the causes of clubbing are again congenital cyanotic heart diseases will lead to clubbing. Only and only cyanotic heart diseases will lead to clubbing. So tetralogy of Fallot, if you examine a child, the full-blown clubbing, right? It's got grades of clubbing. So as you can see on the screen, these are the few grades of the clubbing. Most important is grade 4 is very, very much, and you can totally see it. The causes in RS will include bronchogenic carcinoma, empyema thoracis. So these are the causes. If you have an abscess in your lung, that's also going to lead to clubbing. Next, we've got the GIT. So in the GIT, you've got ulcerative colitis, chronic liver disease that can actually lead to clubbing. Apart from that, there can be differential clubbing, and this will happen if there is some local causes that are pertaining to clubbing. So yeah, this was all the things that you needed to know about clubbing. After that, we go to lymphadenopathy. Lymphadenopathy is basically enlargement of your lymph nodes. Inguinal lymph nodes more than 2 centimeter is pathological, and apart from that, every other lymph node more than 1 centimeter is pathological. So the size of the lymph nodes matters quite a lot. There are 3 main regions of lymph nodes that you can actually palpate. We've got the cervical region, the axillary region, and the inguinal region of lymph nodes that we have to palpate and see if there is any lymphadenopathy present. So the causes of lymphadenopathy can be many. So we've got infectious, that is going to be our main reason why something happens. We can also have neoplastic, so that may be lymphomas of different kinds, as well as your basic diseases. So cancers can go to different lymph nodes. So carcinomas especially go to lymph nodes. Then we have got autoimmune causes and local disorders. So that can also lead to lymphadenopathy. But most importantly, lymphadenopathy, you have to rule out cancer because it's important, and secondly, infection. So that was all about lymphadenopathy. If more than 2 non-consecutive lymph nodes are enlarged, then you have to know that this is generalized lymphadenopathy. So for example, if somebody's got cervical as well as axillary, then it is generalized lymphadenopathy. So yeah, that was about lymphadenopathy. And next, moving on to edema. So edema is basically accumulation of fluid in the interstitial space, and interstitial space, as you know, it's a free space. वहाँ पे कुछ भी accumulate हो सकता है. And to remember edema, the 3 things that you have to remember is the heart, the kidneys, as well as your liver. So these 3 things, if they have any problems with respect to it, it can present as edema, and that can really be very, very, what do we say, painful for the patient. Next, the edema is of 2 types. It's of pitting edema or non-pitting edema. Pitting edema, basically, when you apply the pressure for even just 5 to 10 seconds, you will get a pit which is developed over there, and what will happen is that this pit will stay there. That means it will not come back in the normal way. So that is your pitting edema, and non-pitting edema is the one which is pathological. That means if you put a pit over there, it immediately will come back and become normal again. So non-pitting edema, the causes, my dear friends, include your lymphatic diseases. So filariasis, you might have heard of, Milroy's disease. Okay? All of these lymphatic diseases will lead to non-pitting edema. Otherwise, mixed edema also leads to non-pitting edema. Graves' key pretibial mixed edema of Graves' disease also leads to non-pitting edema. For pitting edema, like I told you, the causes will be heart, liver, as well as kidney. So kidney ki disorders में nephrotic syndrome, nephritic syndrome will present as edema. Heart failure will present as edema. Liver में liver failure will present as edema. So now that I've told you all of this, now actually let me show you how do you examine the patient for all of these particular findings. So Sahil, मैं तुम पे और कुछ थोड़े से investigations करने वाला हूँ, examination करने वाला हूँ. तुम मुझे consent देते हो इसकी? Very nice. उठ के बैठ जाओ. So in here, let me take you first to pallor. So in pallor, always remember you have to do it in natural daylight. We are in a studio recording this, but anyways, natural daylight works best. And you have to retract both the eyelids down and ask the patient to look up. So as you can see, patient ऊपर देखो. So as you can see, the eyelids once retracted, you can see it's nice and pink. That means it's got good hemoglobin. That was how you examine pallor in the eyes. Apart from that, जीभ दिखाओ. Here also the tongue can become pale in causes of anemia. हाथ दिखाओ. So in here you can see the palm as well as the palmar creases. So even the palmar creases can disappear if you have severe anemia. ये palm creases आपको बहुत faint दिखेगी. Apart from that, this thing that is the nail bed as well as the back. So all of this can be examined for pallor, and when the creases of the palms actually go, that is very severe thing. So I hope I have made that clear. Next we'll look at icterus. So icterus में you ask the patient to look down. यहाँ पे देखो, and you can examine one eye at a time. So this is icterus. If the patient has normal bilirubin levels and the patient still has icterus, what you will think of? You will probably think of something like carotenemia. So carotenemia mein the carotenes, that is vitamin A, if the patient is taking exogenously or something. We can also look for the icterus again in the oral mucosa as well as in the palms. The palms will get yellow in jaundice. All right. So this was how do you check the icterus of the patient. Next, we go over to checking the cyanosis of the patient. In cyanosis, the peripheral cyanosis, haath dikhao. So in here, as you can see, the tips, they are not cyanosed. Here, it's completely nice. So in cyanosis, it will be bluish. That you have to remember. And what is the hemoglobin concentration after which cyanosis will develop? So you will need a deoxyhemoglobin concentration of more than 5 grams per deciliter. Not 4, it's going to be more than 5 grams per deciliter. That's when the cyanosis will actually manifest. So in a case of anemia, it's very difficult to see cyanosis. Let's say a person has HB of just 5. Will you be able to see cyanosis? No, it's not possible because the patient does not have enough blood, enough deoxy blood to actually give that bluish tinge. So this is the peripheral cyanosis. Apart from that, you can also check it on the tip of the nose, the ear lobules, as well as the lips. This will be sites for peripheral cyanosis. Central cyanosis you will be checking in the tongue. So jeep dikhao sahil. So in the tongue, you'll be able to check the central cyanosis of the patient. So yeah, that was about cyanosis. Let me check about clubbing. So you can see these, how do we check the clubbing? First of all, we will palpate and we'll do the fluctuation test in the nails. As you can see, what I'm trying to do is I'm trying to fluctuate. Whenever a swelling is there, you can fluctuate that swelling. Case swelling hai, you can press it and you can feel the swelling perfectly. So this is fluctuation. So in here, it's not present because there is no swelling in the first place. You can check it for every single nail. You can check it for this one as well. That is the first thing that you have to do. Next, you have to look at the angle. So here, this is the Lovey-Bond's angle. It is obliterated in your clubbing. Next, we do the Schirmer's sign. So aise karna. So as you can see here, there will be a small diamond which is being present. That diamond will disappear. When you do it, you will see a very, very, very narrow diamond. So when a patient has clubbing, this diamond will disappear. So this is what we call as Schirmer's sign. So you can check the clubbing for each of these fingers. Next, in grade 3 clubbing, you will have parrot beak appearance or drumstick appearance, and grade 4 you will have complete new bone formation over here. Important cause you have to remember bronchogenic carcinoma is important cause of clubbing. So this is how you check clubbing. You can similarly check for the foot as well. After clubbing, we go to lymphadenopathy. In lymphadenopathy, basically we ask the patient to lie down and I'll tell you how to examine it. The patient can be sleeping or the patient can be standing, but you can examine them. So in lymphadenopathy, what we will basically take a look at is the swelling over the leg. So there are 2-3 places. First, this is the medial malleolus, just 2 to 3 centimeters above it. You can push it and you can see if the swelling is there. Of course, you can see it over here as well as on the dorsum of the leg, of the foot actually. And once you can do that, you will be able to see the swelling. You can also see the swelling on the shin over here. This is the shin aspect, the medial aspect of the tibia. If you press it, you will be able to notice the swelling over here. When the shin is involved, it is grade 2. This is grade 1, grade 2. Grade 3 is up to the thighs, and grade 4 is generalized swelling, which we commonly call as anasarca. Anasarca is a marker for kidney disease. So if you have a patient of anasarca, especially a pediatric patient, please have nephrotic syndrome as something in your mind. In adults also, nephrotic syndrome and heart failure should have been in your mind. So that is how you examine for swelling. Now let's go to lymphadenopathy. So here we've got the inguinal group of lymph nodes. You can feel for the inguinal group of lymph nodes along the thigh and the inner thigh, and that's how you feel for the superficial inguinal lymph nodes. Next, we've got the lymph nodes around here. So this is epitrochlear lymph nodes. Over here, you can feel if you can feel any particular swelling. So those will be the epitrochlear lymph nodes. So here I can feel nothing. Then you can feel the axillary. So let me demonstrate how do you do the axillary as well as the cervical exam. Ask the patient to take off the shirt if possible, because that is going to ease the thing. So to check the axillary group of lymph nodes, what do? Firstly, you can check it along this side. So I'm checking the anterior axillary fold. Okay, so I don't feel anything. Then you can go straight away, you can go deep with your thumb, and with your thumb you will be able to palpate a few central lymph nodes which are present. Then you can take it posteriorly. So posteriorly also you can palpate the posterior axillary fold. Now you can ask the patient to keep their hand on your shoulders when you're trying to examine the patient for it. So this is one way to do it, right? Another way is you can ask the patient to keep their hand over here so you can examine the other group of lymph nodes present. So as you might know, there is the anterior group of lymph nodes, there is the posterior group of lymph nodes, there is a central group of lymph nodes which are present over here. Then there is a apical group of lymph nodes. Then we've got the supraclavicular lymph nodes and we've got the infraclavicular lymph nodes. To palpate the lateral group, you press against the humerus. That's how you get the axillary artery and the lateral group. So let me just quickly revise. The lateral group will palpate like this. Anterior group, you ask the patient to keep his hand over here, and using your other hand, you can palpate the other group of lymph nodes. Similarly, for posterior group, you ask the patient to keep his hand over here, and you can insinuate your hand and find the posterior group. For central group, you can let the hand be round. You can put your hand, insinuate your hand, find the central group in the deepest part. Here you can check for the infraclavicular group. Here you can check for the infraclavicular group, and here the supraclavicular. Very important to note is that in supraclavicular lymph nodes, you have to keep the gastric malignancies in mind, especially of the left side. So here, left supraclavicular lymph node, it is called as Strauss's sign. In gastric adenocarcinoma, that is the sign positive. In breast cancer in females, very essential to examine both sides of the lymph nodes which are present. So that's how you do this. Next, what we'll go over towards is the examination of the lymph nodes of the neck. So there are lymph nodes here. We've got level 1A, level 1B. So this is submental, submandibular. Then we have got level 2, 3, and 4. So level 2, 3, and 4 is along the sternocleidomastoid. So level 2 is upper, 3 is middle, and 4 is lower. Then we've got the level 5 lymph nodes. Level 5 lymph nodes are present posteriorly over here. Level 6 lymph nodes are present in front of here. This is called the central lymph nodes, and level 7 are inside. That is in the mediastinum. So how do you check for this? Submental, you check like this. Submandibular, you check like this. Apart from this, you can check the pre-auricular, the post-auricular, and you can check if there is any relevant swellings which are over here present. Then according to the sternocleidomastoid also, you can check if there are any lymph nodes present. Anteriorly, posteriorly, occipital lymph nodes also you can check. In central, as such, you won't find that many lymph nodes. So yeah, this on level 7 we cannot check. So this is how you check the lymph nodes, and that basically completes your basic Piccle wala examination. Now let's go to JVP, that is the jugular venous pressure.